Thank you. Okay. Okay. Good afternoon, everyone. Thank you for the kind introduction. Before I begin, let me just thank Hyphens Pharma for the kind sponsorship for this talk. And for the next 40 minutes or so, I shall discuss about the metabolism of vitamin D, how vitamin D works on our various organs like bones, muscles, cardiovascular diseases, and the brain. So how do we define an optimal level for vitamin D? And for the patients who are low in vitamin D, what is the current trend and recommendations for the replacement therapy? Now, just a quick introduction now. Vitamin D is actually a fat-soluble vitamin found in various food items, especially fatty fish. Our skin also, of course, synthesize vitamin D from the action of sunshine. But as we grow older, this mechanism of making vitamin D from the sun is not as efficient compared to when we're younger. Now, if somebody who works all the time under the sun, they actually get melanin deposits, and that's the way the skin protects against skin cancer. But melanin actually inhibit vitamin D synthesis. So meaning to say people who are darker in color, in skin color, are more likely to be vitamin D deficient. Sunshine is free, all of us, everywhere, but worldwide, actually, about 1 billion people have low vitamin D level. Although currently there's no agreed cutoff to define vitamin D deficiency. Now, vitamin D metabolism as we knew it from medical school. Okay, so this is what I was taught in medical school. So our skin manufacture vitamin D, and the food that we take also contain vitamin D, and that would be in the form of cholecalciferol, which circulates in the blood, go to the liver, and get activated by addition of a hydroxy group in the liver. So that forms 25-hydroxy cholecalciferol. This is not really the active form of vitamin D, although the half-life is the longest among the various forms of vitamin D. So the potency is low. So if we need vitamin D to work effectively in the body, it needs to be converted again to 1,25-dihydroxy cholecalciferol in the kidneys. So dihydrocholecalciferol is the most active form of vitamin D, but the half-life is only about 4 to 6 hours. And the effect of activated vitamin D, 125-dihydroxy cholecalciferol, is to increase the calcium level in our blood. And the way it does this is firstly it acts on the bone to cause demineralization of the bone so that calcium can be released and circulate in the blood. Of course, it also acts on the GI tract to increase intestinal absorption of calcium from the diet. And lastly, low calcium level also stimulate our parathyroid glands, causing secondary hyperparathyroidism. Secondary hyperparathyroidism then works on the bone also to release calcium so that our calcium level does not drop to a dangerously low level. Nowadays, in addition to the calcium metabolism, we know that vitamin D has a role in our immunity, in our immune system. As suggested by COVID infection, for example, we learned that people with low vitamin D, if they catch COVID, they tend to become very ill. Respiratory tract has a role also, like I discussed a bit earlier. There's a role of vitamin D in the pancreas. People with low vitamin D tend to develop type 1 diabetes. Intestinal and bone action, skin effect, we have already discussed. Now, muscle health is very important, especially when we grow older. So people with low vitamin D tend to have weaker muscles and smaller muscles too. We also are hearing things that low vitamin D has an impact on our blood pressure, our peripheral artery system, coronary artery disease, and AF. And in the brain also, vitamin D is also linked to dementia. So vitamin D is not just effective on elevating the serum blood calcium level. It also have actions in various organs. So vitamin D circulates in the blood either as free vitamin D or it is bound to a protein like vitamin D binding protein or bound to albumin. And the bound vitamin D enters the cell through vitamin D receptors. And vitamin D intake and how much is the optimal level is still a bit controversial. But generally, we recommend vitamin D intake of about 800 to 2,000 units a day. Alternatively, if this compliance is difficult, especially among the elderly with a lot of pill burden, we can do 25,000 or 50,000 international units a month. So that saves the pill burden. So how much vitamin D is adequate and how much is deficient? So if we look at vitamin D level measured in terms of 25 hydroxy vitamin D, so D2, less than 20 is defined as deficiency, vitamin D deficiency. Below 30 is insufficiency, and more than 30 is classified as optimal. Now, how do we define optimal vitamin D level? So it is at the level where hypoparathyroidism does not occur. So PTH hormone is suppressed. It is also at the level where the fracture risk is the lowest and the renal production of vitamin D3 is at the best. So the optimal concentration is currently recommended to be somewhere between 20 to 40. But minimum, American Geriatric Society recommend a level of more than 30 for the elderly to reduce the risk of falls and fractures. Here in Singapore, we get sunshine almost the whole year round, but the vitamin D level is not as good as we think it should be. So this is a study published by the Tan Tock Seng Auto-G group. So look at people who got admitted for hip fractures. And we realized that actually only 8% of the elderly in Singapore have sufficient vitamin D. So which is that is defined as vitamin D2 level more than 30. The others are either deficient or insufficient. So only 8% have adequate vitamin D. And among the races in Singapore, the Malays tend to have lower level, perhaps because of the way they are dressed, all covered up, including the headscarf. Now, the other people who are also at risk of low vitamin D, of course, include people who are housebound and people who need assistance with the activities of daily living, or those taking inducing enzymes like, so enzyme inducers like anticonvulsants such as phenytoin, valproate, phenobarbitones, which are quite rare nowadays. People in nursing home or recurrent hospitalizations because of the lower exposure to vitamin D are also at risk. Primary hyperparathyroidism because the bones is actively churning out calcium all the time. Protective clothing, full sunscreen use, living in the northern altitude, especially dark-skinned individuals, are also at risk of vitamin D deficiency. If we have a GI malabsorption syndrome, like gastric surgery, inflammatory bowel disease, or celiac disease, these are also at risk of vitamin D deficiency. So should we screen for vitamin D deficiency? The answer is yes, especially the elderly who had a history of falls. Because once you have screened it, the blood test is relatively fast and quick to do. It's not so expensive. And once it is proven to be low, we have very good treatment available. So therefore, screening is cost effective for vitamin D deficiency. So what happens in vitamin D deficiency is that it leads to low serum calcium, vitamin D, calcium and phosphate level. So low calcium and phosphate level then triggers secondary hyperparathyroidism, and chronic hyperparathyroidism leads to bone loss, causing worsening of osteoporosis. And in extremely low vitamin D levels of less than 12, we can actually get osteomalacia or rickets. So effectively, when we are talking about bone disease, like osteoporosis among the elderly, we have two components. One, we have the bone disease itself. The other one is mineral problem with calcium, phosphate, and vitamin D. Okay, so vitamin D deficiency presents with bone pain, muscle weakness, and of course fractures. And the hyperparathyroidism itself, because of low vitamin D, will present with demineralization of the bone. So the BMD will get worse with aging. So in terms of bone health, what we are interested in is osteoporosis, because osteoporosis contributes to about 9 million fractures worldwide annually. Now, osteoporosis fracture is silent. So a lot of the time, we do not know that we have osteoporosis until a fracture occurs. So if it is a fracture, even after you fix it surgically, it is going to affect your quality of life. Physical health, psychological health, function, all will be affected. And at the end of the day, it is going to make the elderly or the individual with osteoporosis become more dependent on the caregivers. It may cause chronic pain, and mortality will also increase because of osteoporosis. Early diagnosis and treatment actually can maintain the bone density and prevent osteoporosis among early postmenopausal women. Now, if you look at men and women are more likely to get osteoporosis, including osteoporotic fractures in their lifetime. And the older you live, if you live until 80 to 90 plus, your risk of osteoporosis fracture is higher compared to the younger elderly. Now, once an older person sustains an osteoporotic fracture, like hip fracture, mortality is about 20%, if not more, in the 1 year post fracture. Osteoporosis, like most of the chronic diseases, is a silent disease. We live with osteoporosis like we live with diabetes mellitus without knowing that we have the disease until something bad happens. So if you look at a picture of bone, so we have two types of bones in us. One is trabecular bone, the other one is cortical bone. So trabecular bone is where the marrow is, in the center of the bone. Cortical bones are on the outside. So the cortical bones are the scaffolding. They are the ones that hold the weight. Trabecular bone, on the other hand, is to maintain metabolism and calcium store. Now, trabecular bone is actually not a solid organ, and in fact, it looks like sponge, right, with holes in between the bone substance. So as we grow older, if you develop osteoporosis, you will find that the holes get bigger, right? Not only the holes get bigger, the bones in between the holes get thinner and weaker. And because it gets thinner and weaker, it is more likely to fracture. So this kind of bone, if you look at the right lower picture, osteoporosis, this kind of bones is very easy to fracture. It is crunchy like biscuits, if you like. So for a normal trabecular bone, like the upper left corner picture here, in order to fracture this bone, you need about 1,000 kg in weight. But if you have osteoporosis, you don't really need any weight. Just coughing itself can cause fractures. And you wouldn't believe it, during COVID, we actually saw a lot of vertebral fracture just by the aggressive coughing. So if you want to treat osteoporosis, there are two pathophysiological changes that occurs in osteoporotic bones. Now, the first is an imbalance between bone resorption and bone formation. So our bone is not a static dead organ. It is alive. It is turning over all the time. Now, the turning over is actually good to maintain the bone density. So what stimulates the bone to start turning, resorbing, and building new ones are things like exercises, weight-bearing exercises, strain, trauma to the bones that cause microfractures, hyperparathyroidism or steroids can induce this turnover effect to start. So what happens in your bone is that you get these two classes of cells. One is called osteoclasts, the other one is called osteoblasts. Now, osteoclasts get activated first. So they come along, eat away the dead bones or the old bones, and closely following behind will be your osteoblasts. So your osteoblasts will lay down the bones to fill up the holes that the osteoclast left behind. It's a bit like brick layering, if you like, or scaffolding, layering on the cement and the bricks after osteoclasts eat away the damage and the old bones. So if you're young and if you don't have any other medical issues, this process is equal. So bone resorption equals bone formation. So at the end, you get good, strong bones. Now, as we grow older, especially ladies in the immediate postmenopausal period, perimenopausal actually even, we have osteoclastic activities that are much more active compared to the osteoblastic activities. So what that means is you've got big holes left over by the osteoclasts, and the osteoblasts are lagging behind. So the bones at the end turn out to be weaker. The holes are bigger. That's why. So osteoporosis is actually an imbalance between bone resorption and bone formation. The other problem is mineralization. So once you have new bones being laid down by your osteoblast, it needs to be made stronger. And the way that it is going to be stronger or weaker depends on the amount of calcium phosphate that the bone has. So if we don't drink enough milk, we don't take in enough calcium in our diet, the new bone will be weaker, right? So this is what happens if you don't eat enough calcium in your diet. Your serum calcium is going to drop. Now, serum calcium would not be allowed to drop to a dangerously low level because calcium is essential for our heart to function, for our neurons to function. So if the calcium drops to too low level, we are going to get arrhythmias, which is not desirable. So therefore, once the calcium start to drop, even at a minute amount, the parathyroid hormone will be stimulated and vitamin D will also be stimulated. So these two together aims to bring up the calcium level. So how this work? Parathyroid hormone is going to act on the bone to get the bones to throw out more calcium. So the bone actually get demineralized to release the calcium. Vitamin D similarly also acts on the bone as well as acting in the GI tract to increase calcium absorption from the diet. So this, in the long run, is bad for the bones. So if you take in enough calcium in your diet or you take calcium supplement, the calcium that is circulating in the bloodstream will be sent to the bones to be deposited on the new bone so that the new bones will be just as strong compared to the old bones that have been eaten away. So the importance of bone mass that cannot be overemphasized. Okay, so if you look at this bone mineral density across our lifespan, all of us reach our peak bone mass by the time we are 30. So young adults have the peak bone density. Men have higher bone mineral density compared to ladies because men are bigger in terms of height, in terms of body weight. They're broader and bigger than women. So therefore, they need a higher BMD compared to the ladies. So if you look at this graph here, we have two. We have the green ones for the men, and we have the pink one at the lower level for the ladies. So you can see that for both men and women, we reach our peak bone mass by the time we are about 30. And thereafter, it is a slow decline due to aging. Okay. Now, for ladies, there are a couple of reasons why the decline is a bit sharper. First, because if they have children, if they don't eat enough calcium in the diet when they are pregnant, the calcium for the babies will also come from the ladies' bones. The other thing you notice, there is a sharp decline round about age 40s or mid-40s onwards until mid-50s. So this is the perimenopausal years. So even before the period stops, when the estrogen level is dropping, osteoporosis is already starting. The bone mass is already dropping. Then after that, after the age of about 60 onwards, the decline is slower and smoother again due to aging. Now, men, fortunately, do not go through the equivalent of menopause, so they don't have that sharp decline. So their decline in the bone mass is just a gradual process for aging. Okay. Now, if you look at the two types of bones we mentioned earlier, we have cortical bone and trabecular bone. So trabecular bone turnover is faster. It turns over at the rate of about 26% per year, whereas cortical bone turnover at the rate of 3% a year. So that means if you have a bone disease that affects turnover, like hyperparathyroidism, like Paget's disease, like osteoporosis, trabecular bone will be affected first. So osteoporosis can either be primary or secondary. So primary osteoporosis is due to aging itself, right? So ladies, postmenopausal osteoporosis occur because of the drop in the estrogen level. And after that, it is senile or senescence due to aging itself. Okay, so primary osteoporosis should be a diagnosis of exclusion in your practice if you see young people with osteoporotic fracture. So young people come in with presentation typical of fragility or osteoporotic fracture should not be labeled as primary osteoporosis. We need to look for secondary causes of osteoporosis, and the list is quite long. But if you can't remember all of these, just pay special attention to the fonts written in blue. So heavy smoker, heavy alcohol consumption, or very thin people are more likely to get osteoporosis, especially if they have vitamin D deficiency or low calcium intake in the diet, or they lead a very sedentary lifestyle. Endocrine diseases like diabetes, like hyperparathyroidism, like thyrotoxicosis are also at a higher risk of developing osteoporosis. Hypogonadal state. So for people with early menopause, either it is a surgical menopause, for people with ovarian cancer, for example, or people like Turners who have never had a period, or men with Klinefelter's XXY, so their testosterone level is abnormal. So these endocrine patients are the higher risk. If your patient has chronic kidney disease on loop diuretics, because loop diuretics cause a loss of calcium in the urine. GI diseases causing malabsorption, celiac disease, inflammatory bowel disease are of course at risk. Neurological disease, Parkinson's, stroke, or people on anticonvulsants. The reason why the major degenerative diseases are at a higher risk is because of immobility, right? Parkinson's disease, stroke disease, dementia, their mobility is probably going to be less compared to their peers. Multiple myeloma causes secondary osteoporosis by interrupting or the myeloma cells taking over the healthy bone. Rheumatological diseases or autoimmune diseases are also at a higher risk of osteoporosis because of long-term steroid use. So clinical features, again, osteoporosis is a silent disease until they develop a fragility fracture. Now, the most common complaint of osteoporosis is actually a loss in height. So if you see ladies, especially who are getting more and more stoop, more and more kyphotic, and if the family think that they are losing height, okay, so definition of height loss is more than 2 cm from their last measured height is significant. So osteoporosis fracture can occur anywhere along the vertebra. So in the thoracic column, most likely, most often is where it starts. They get kyphosis, and if very severe, can actually cause restrictive lung diseases. Lumbar fracture give rise to lower back pain that may interfere with the mobility and crowding of the abdominal organs, so the abdomen tend to protrude. And all this cause disability, functional decline, poor self-image, social isolation, depression, and inability to carry out their day-to-day activities of daily living. So how do we diagnose osteoporosis? Well, there are two ways to diagnose osteoporosis, either by BMD, bone mineral density test, or the presence of fragility fracture. So fragility fractures are defined as fractures that occur with minimal or no trauma. So if you remember a bit earlier on, I said if I were to fracture a young man's bone, I need 1,000 kg of weight. But for the elderly, they don't need to be impacted with such high level of weight. So 1,000 kg of weight is equivalent to being hit by a car. So for osteoporosis, all they need to do is cough or hit themselves on against the wall. They can easily fracture. Now, Trabecular bone turnover is faster than cortical bone, as I mentioned a little bit earlier. So that will determine where the fracture starts. Now, vertebra are mostly trabecular bones. 80% of vertebral bodies are made of trabecular bones. Hence, vertebral fractures occur first in osteoporosis. Hence, the loss of height may be the first symptom that your patient has osteoporosis. So if you have vertebral fracture due to osteoporosis, you will see that your vertebral body actually gets shorter and shorter. Yeah, so that's why it's loss of height. The second to occur would be the wrist fracture. So it occurs at about 1 inch from the wrist joint. So this will be at the radial head, causing a Colles fracture. And after that, then you get your long bone fracture because your cortical bones will be affected by then. So you have neck of femur fracture, intratrochanteric fracture, or head of humerus fracture. So head of humerus fracture is also now classified as fragility fracture. Definition of osteoporosis according to BMD is minus 2.5 or below. Okay, so between 1 to 2.5 is osteopenia. Then for those of you who deal with ladies with vertebral fracture, sometimes you send them for BMD, they come back, you realize actually their BMD is not even in the osteoporotic range. It is only in the osteopenic range. Yeah. So between minus 1 to minus 2.5. So it's osteopenia. They can also fracture at that stage. So management of osteoporosis consists of pharmacological and non-pharmacological. So non-pharmacological include lifestyle changes, like encouraging our elderly to exercise and do resistance training. So physical exercise, especially aerobic exercises, will cause micro fractures in the bones. Even jumping on the spot is good enough for osteoporosis bones to heal and to encourage improvement in the BMD. Okay, so maintain a BMI of more than 20 actually. BMI under 19 or under 20 is unhealthy for the elderly. So for the elderly, I usually advocate a bit on the plump side because their overall health is better. High calcium and high protein intake is important to maintain a bone health, stop smoking, and avoid high alcohol consumption. Now, in terms of pharmacological treatment of osteoporosis, I have classified that into several components. So the first thing that we do for osteoporosis treatment is actually not the anti-resorptive or hormonal therapy. We need to take care of the minerals first. So by minerals, we're talking about calcium intake, ensuring that our elderly are taking at least 1.2 gram of calcium a day. Now, this calcium intake should be from the food source first. Okay, so if your elderly is not eating enough, then we supplement with tablets. And vitamin D minimum is 800 to 1,000 units a day for maintenance. But if your patient have lower vitamin D, less than 20, then the replacement is slightly different that we'll discuss a little bit later on. So if your patient cannot remember to comply with this, then perhaps it's easier for them to take 25 or 50,000 units a month. So just the vitamin D drops is made perhaps easier. Then you look at drugs to manage the bone resorption and bone laydown. So we have anti-resorptive agents like biphosphonate or denosumab. We have hormonal drugs like selective estrogen receptor agonist, HRT or PTH. And we have the newer therapy biologics like romosozumab that we can also discuss a bit later. So for vitamin D deficiency, level less than 20, right? So we recommend using the recommendation currently, sorry, not what we recommend. The current recommendation is we have to replace the deficit first. So the deficit is actually 400,000 units. So for people with low vitamin D, less than 20, we need to replace the deficit first. 400,000 units in 6 to 8 weeks. So the way we do this, we do 50,000 units once a week for 6 to 8 weeks. Okay, after the replacement for the deficit, we go on the maintenance therapy. So maintenance therapy is 800 to 1,000 units per day. So if your patient have vitamin D level between 20 to 30, 600 to 800 units per day is enough. Or alternatively, you can give them the drops, which is 25,000 to 50,000 units a month. Now, so for people with low vitamin D, right, some of you might argue, why do we need such high dose? Would the high dose cause a hypercalcemia problem? Hypercalcemia problem, no. So what's the difference between replacing maybe 1 or 2,000 units over time to replace the deficit of 400,000 units? You can try, but it is, if you look at this study here, it will take very long, and not only does it take very, very long, it will not hit the optimal vitamin D level, right? So it is easier just to give them the vitamin D drops for 8 weeks at 50,000 units per week. After that, we do the maintenance therapy. And how do we work up for vitamin D deficient patients? You need to check the renal panel. Sometimes they have CKD. So if they have CKD, they cannot convert from D2 to D3. So maybe that's the problem. You also need to check the calcium and phosphate level, but usually the calcium and the phosphate level are at the borderline low. They are not too low. Good to check the liver function, parathyroid hormone, and to make sure that your patient doesn't have a malabsorption problem. So the proper drug management for osteoporosis, the commonest will be the anti-resorptive drugs like bisphosphonate or denosumab. So these two work by inhibiting osteoclastic activities. So if you remember, osteoclastic activities are to do with breaking down the bones. So we want to stop the bone being breakdown, right? So we inhibit osteoclastic activity, we stop the resorption. But this group of drug does not do bone formation. So there is no increase in the bone mass for people on this group of treatment. Data is good. These drugs have both been around for very long. It reduces hip fracture, vertebral fracture, as well as non-vertebral fracture. Okay, the difference between biphosphonate and denosumab, biphosphonate is contraindicated for people with GFR below 30. Denosumab can be used for people with advanced kidney failure. Biphosphonate inhibits the osteoclastic activities by about 70-75%. Denosumab inhibits 100%. Okay. Now, good to remember also, these two groups of drugs, if you stop, there may be a rebound risk of increased fracture. Okay. So if you stop denosumab or you stop biphosphonate, you have to remember to check your patients a bit more regularly because they are at a higher risk of fractures, especially vertebral fracture. Now, what about anabolic agents? Can we increase the bone mass for our osteoporosis patients? So earlier we talked about stopping the resorption, but can we lay down more bones so the bones are stronger? Well, yes, we can do this. There are two options for you if you want to consider this. There's the parathyroid hormone injection or the romosozumab injections. Now, you did not hear wrongly. Parathyroid hormone is also the cause of osteoporosis because it mobilizes the calcium from the bones throughout to the blood to maintain the serum calcium level. Yes, correct. You heard correctly. So that's chronic primary hypoparathyroidism. Now, the difference between chronic primary hypoparathyroidism and subcutaneous teriparatide or parathyroid injection is that the short pulses of parathyroid hormone that we give actually cause an anabolic effect, right? But it is not as great as you think, because parathyroid hormone is parathyroid hormone, whether synthetic or natural. It will also stimulate the osteoclastic activities. It's just that in the first 6 months of giving your patient synthetic parathyroid hormone, the osteoblastic activities outweighs the osteoclastic activities. So for the first 6 months of treatment, you have a net gain in bone mass. But after 6 months, the gain is still there, but it is not as good as the first 6 months. It begins to slow down. Hence, both parathyroid hormone and romosozumab treatment is recommended for only about 1 to 2 years and followed by anti-resorptive drugs to stop the new bones that have been gained from breaking down. Okay. Yeah, so current recommendation for parathyroid hormone injection is 24 months, and then you must follow it with biphosphonate or denosumab to stop the new bones from being broken down. Romosozumab injections are recommended for postmenopausal ladies, but not as the first line. Okay, so you try other agents first, like biphosphonate, like denosumab. If they are still getting fracture, if the FRAX score is still high, or if the BMD continue to drop, you may wish to consider switching to romosozumab. Both these drugs are expensive. Okay, so romosozumab is recommended for 1 year. Now, romosozumab has not much data for men. So the current recommendation is postmenopausal women, not men. And romosozumab is associated with a higher risk of stroke and heart attack. So for ladies who had a stroke history or heart attack history in the last 1 year, is not recommended for this therapy. And currently there are research ongoing for giving romosozumab to men. So we await the results. So which one should you go first? Anabolic agents or anti-resorptive agents? Now, the current trend of thought is that we should go for anabolic agent first. Build up the bone mass, and then we stop the bone breaking down. But the only problem is cost. And currently in Singapore, anabolic agents are only prescribed by endocrinologists. So most of us are still using either biphosphonate or denosumab as a first line. But even as those two as first line, please remember you have to make sure the calcium and the vitamin D levels are repleted first before you start those. Now, for the young, early postmenopausal ladies in the mid-50s to the early 60s, you may consider hormone replacement therapy or selective estrogen receptor modulators like raloxifene. Now, raloxifene is also helpful for ladies with a family history of breast cancer. Okay, so the indications for HRT or SERMs include ladies with problematic hot flushes, osteoporosis, and like HRT, there is a risk of venothrombosis. So you have to warn them of this. HRT has received very bad publicity in the recent years because of the increased venothrombosis, cardiovascular risk, glucose intolerance, etc., etc. So, but they are not really excluded because nowadays the hormonal combinations are more physiological. So you can discuss with your patients, at least let them have a choice. But the thing to remember for SERMs as well as for HRT, it is not recommended to do this treatment for more than 5 years. Okay. Testosterone may be indicated for men with high fracture risk, but same as HRT in ladies, same metabolic problems, and of course the risk of prostatic cancer to consider. What about vitamin D, role outside bones? So vitamin D now we know has receptors everywhere. Okay, so it is now known that low vitamin D level has a is related to a higher risk of cancer, autoimmune diseases, cardiovascular diseases, muscle health, even infection risk, even dementia risk. But the the frustration for most of us is we want to know, okay, so that's all good. So what is the optimal vitamin D if I want to prevent all these extraskeletal diseases? The answer is nobody knows. And should we treat or what should we do if we don't want to get all this? Should we take extra vitamin D supplementation? Again, nobody really knows the answer. So we look at sarcopenia first. So sarcopenia is a loss in the muscle mass and loss in the muscle bulk and strength as we grow older. So this is an aging problem. So what happens to our muscle is that as we grow older, the muscles get smaller. Not only it gets smaller, it gets replaced by fat and fibrous tissue. So if you can imagine when you're younger, your muscles look like the cheap beef in NTUC. But as we grow older, the muscles look like the Wagyu beef. Okay, so full of marbling, full of fat, full of fibrous tissue. It's very weak. So the problem when we develop sarcopenia is that it will affect our physical performance. So we are more likely to fall. We are more likely to become dependent on our caregivers. We are more likely to develop swallowing problem, respiratory function, frailty, and after that, osteoporosis and fractures. So how do we check or how do we make sure we don't have osteoporosis? Sarcopenia. So for sarcopenia, because it requires loss in the muscle bulk, so we do this by measuring the calf circumference, okay? And the strength, we measure by using grip strength. So we have this dynamometer, and we have a newer handheld device coming up soon that are in the midst of validating. And of course, physical performance like gait speed or sit to stand. Yeah, so this is the muscle that you look at. So this is a CT scan of a young person's muscle, nice and red. Muscles of an older person, very much infiltrated with fat and fibrous tissue. Like the bone mass, we achieve our maximum muscle mass in our early adulthood, in our 30s. After that is a decline, okay? So if you don't put in the exercise, if you don't take care of your muscles by eating well and exercising regularly, your decline in the muscle health is going to be faster compared to your peers who exercise on a regular basis. So what that translates to is that as you age, you are more likely to develop disability. So if we have this arbitrary line where we will become totally dependent on our caregivers, for somebody who doesn't exercise, they will get there soon. Okay, sooner compared to somebody who exercise regularly and eat right. So for this person who exercise regularly and eat right, so by the time hopefully at their deathbed, they are still relatively independent. That's what we are saying. So even though sarcopenia is a problem with the aging process, you can slow down or you can even, I don't think it's possible to reverse. I think you can slow down your muscle loss by eating enough protein in your diet, as well as doing cardio and and resistance training. So once you develop sarcopenia, you're at risk of falls, right? Going to a nursing home because you're going to lose your independence and become disabled. Your risk of respiratory, cardiac diseases, osteoporosis, fractures, and even dementia is higher compared to somebody with healthy muscle in their older age. So sarcopenia, the clinical features include muscle weakness, loss of stamina, trouble performing usual tasks like walking, like even unscrewing the caps of bottles is a sign that sarcopenia may be setting in. Loss of balance, they are also more likely to fall. Smaller shrinking muscles that you can see either on the chest wall or on the upper limb, your upper arm, or even wasting in the small muscles of the hand. And then their gait speed becomes slower. Climbing stairs become more of an effort. So aging is the main trigger of muscle loss. And this process actually starts in our midlife. So by the time you're 40, you have to eat right, okay? So if you eat a diet high in fat and low in protein, you're also more likely to develop sarcopenia. If you have chronic diseases, especially if they're not managed well, this will also encourage sarcopenia. If you are overweight, so if you're overweight and you have sarcopenia, put it together, you have sarcopenic obesity. Sarcopenic obesity is even worse compared to sarcopenia or obesity alone, okay? Because sarcopenic obesity makes it harder to exercise and cause insulin resistance because of the heightened amount of fat cells that you have in your body. Sedentary lifestyle is another predisposing factor to sarcopenia. So if you don't exercise, your muscles will get smaller and weaker faster compared to an active adult. So what can we do to prevent sarcopenia? Well, good diet is important, a diet high in protein. Now we know vitamin D is also important. So take enough vitamin D either by food or supplement or going out to get enough sunshine. Now, if you want to get sunshine, you need to get 20 to 30 minutes of good sunshine exposure every day in order to achieve good vitamin D levels in your blood. Regular exercises with a combination of cardio as well as resistance training. If you have chronic diseases like hypertension, diabetes, hyperlipidemia, COPD, make sure it is well managed. So as GPs, we also want to make sure that all the cardiovascular risk factors, all the diabetes are under control. Vitamin D supplementation actually has been shown, well proven in studies, to increase the muscle mass and the muscle strength. But because the studies are quite variable in terms of their outcome measures, we cannot be sure that the pure increase in the muscle mass and strength alone can translate to functional outcome like fall risk, like gait speed, like balance, okay? Because different studies measure different parts of the body, whereas we know vitamin D mostly affect the proximal muscles, okay? Now, tell your patients medications cannot work for muscle mass. They still need to gain or maintain their muscles the hard way by exercising. Vitamin D also has a role on our cardiovascular health because vitamin D receptors are present in the vascular endothelium, the smooth muscle cells, as well as our heart cells, the cardiomyocytes. And these cells also can activate the vitamin D on their own. So vitamin D is associated with cardiovascular diseases in many ways. It is involved in the renin-angiotensin-aldosterone activation system. It interferes with the endothelial functioning, causes increased risk of atherosclerosis, oxidative stress, inflammation, causes a higher risk of hypertension, diabetes, cardiac hypertrophy, and myocardial fibrosis. Okay, but what is the optimal vitamin D level for reducing all these cardiovascular risks? We don't know actually. But all we can tell you is vitamin D deficiency leads to all of this. So in other words, it is probably better to aim for a normal vitamin D level, right? What about dementia, which is my pet topic? So vitamin D crosses the blood-brain barrier by binding to the vitamin D receptors on the various cells in the brain, like neurons, the glial cells, especially in the hippocampus and thalamus, the memory areas. So vitamin D actually exerts a neuroprotective effect on these brain cells and the neurotropic effects. So neurotropic effects is important in neuroplasticity. Meaning, if you have a stroke, for example, you don't want the dead neurons to extend or continue to die off. You want some sort of neuroplasticity so we can recruit the neurons from other parts of the brain to do the same thing as the neurons that have been affected by the stroke. Okay, so that's neurotropic effects, neuroplasticity. Vitamin D also reduces formation of phosphorylated tau and amyloid, which we know is related to Alzheimer's disease. And vitamin D also has been shown to upregulate the genes involved in synapses formation. So if you get new synapses, it's good. It will be protective against dementia and promote hippocampal neurogenesis, which is what we want. So hippocampal atrophy is the hallmark of Alzheimer's disease, is where the short-term memory is affected. Again, we don't know what is the optimal vitamin D level to prevent dementia. All we know is that low vitamin D level of below 20 is associated with all-cause dementia. And vitamin D more than 20, where supplementation is involved, is unlikely to produce benefit. So about 20 is probably the best. Vitamin D level is also linked to cerebrovascular pathology like thrombotic strokes, large vessel infarct, as well as small vessel disease like white matter hyperintensity. Vitamin D supplementation has been associated with 40% reduction in dementia incidence. Okay, and this effect is even bigger among female, among people who are not apolipoprotein E4 gene carriers. So apolipoprotein E4 gene carriers have an increased risk of Alzheimer's disease. So possibly if we take care of our serum vitamin D level, it can potentially prevent dementia. So in summary, vitamin D deficiency is common among us, we know, right? So more than 80% of us, or if not 92% of us in Singapore have low vitamin D, even if we live in the tropics with daily vitamin D. Routine screening is not widely practiced, but at least we can do it for elderly with a history of falls or sarcopenia. So screen for vitamin D level, and as an opportunistic event, like if you see a patient who had a near fall or looking very thin, losing weight, just do a vitamin D level, because if the level is less than 20, we can treat this very easily and the outcome is good. Okay, thank you very much for your kind attention.